to think about kids coming into A&E, how they might present, and so that you could just start thinking about what might be going on here, what kind of guidelines might I want to be looking up, what kind of support might I need, because no one's expecting you to have all of this at the tips of your fingers and kind of indelibly etched in your brain. There are very good guidelines around to follow. So this was the first case that we gave to you. So a young boy brought in by ambulance in the middle of early morning, had a couple of days of coryzal symptoms, a bit of a mild fever, and then overnight had suddenly deteriorated with really problematic coughing to the point of retching. And parents were really concerned about his breathing because he was struggling so hard. It sounded very noisy, and he had this really persistent, noisy cough. And those are his triage observations on the side. So tachycardic, but he's crying, tachypneic, but he's crying. Saturations are okay, and they haven't attempted a blood pressure. Thoughts from the floor as to what you think might be going on here? Is there any more information you'd like from me? Oh, it's going to be a really long teaching session if no one talks.
Personally, I'd like to know what kind of cough they have.
If I told you it was a barking cough, Fiona.
Well, that would make me think about one particular problem.
F2s?
Also, what the noisy breathing sounds like, whether it sounds like stridor.
So it does sound like stridor. Do you want to explain what you mean by stridor? Can you imitate it?
So, like.
I can do
That's
it.
not bad.
Yeah.
So a harsh inspiratory noise, isn't it? So yes, he's got stridor at rest and he's got a barking cough. So what do we think the diagnosis is?
Epiglottitis?
Did you say epiglottitis?
Yeah.
So it could be, but that's pretty uncommon. So the far more common thing is croup, so viral croup. And it's probably one of the commonest presentations with acute respiratory distress caused by an upper airway issue that you're going to see in kids. And it's most commonly seen in the preschoolers, but we do occasionally see it in older children as well. The list of differentials is there, but we hardly see those. So, you know, if you've got a really toxic kid, then you're going to be thinking, could this be tracheitis? Could this be epiglottitis? But we don't see anywhere near as much of that anymore because it, particularly epiglottitis, was usually caused by Hib. And because of the uptake in immunisations, we really don't see it very often anymore. So, and things like diphtheria, again, covered by our immunisation schedule. So viral croup is absolutely barn door common. So if the history fits with that and it's the right age, I would treat that. And if they're not responding to therapy, or if they keep coming back in and it's a bit unusual, then obviously, or if the history is a bit different, then you have to start thinking of the weird and wonderfuls. But the weird and wonderfuls are pretty rare. You will get a copy of this presentation, so don't feel you have to scribble everything down. So when you've got croup, the most important thing is that these kids are just about holding on at the moment when they come in, but they can tip over very easily into worse respiratory distress. And what you really don't want to do is precipitate a respiratory arrest because you've done something to them. So the most important thing is please don't upset this child, which is quite hard to do because they're coming into ED. You'll probably bring them into resus. There's probably, you know, a drunk, aggressive, alcoholic adult next to them. It's bright. There's hundreds of people around. You put out a resus call because they were brought in by ambulance and the ASHI sounded terrible. And you've got all of these people, all of this noise, all of this bustle, and it is terrifying. And sometimes the most important thing you can do for this kid is put them on the parent's lap, give them a tube so they can get a bit of wafting oxygen somewhere near their face without distressing them too much. turn the lights down, close the curtains, and try and get rid of some of the people that are scaring the child. And then you're going to want to assess the severity of the obstruction, bearing in mind that the volume is not going to be particularly helpful. So you're looking more at kind of their work of breathing, their tracheal tug, what their saturations are they confused? All of those kind of things are going to be red flags that this is pretty severe. And obviously, as you go on, if you have overwhelming respiratory distress and you're decompensating, then you can tip into arrest. You can then tip into cardiac arrest. And if it is one of the weird and wonderfuls and they're toxic, then they can be shocked from a cardiovascular point of view as well. So you have to consider that. But though all of those things are really rare, what's much more common is that you've got a preschooler coming in that sounds terrible, but if you can calm them down, they start sounding a bit better. And if you can get some oral dex into them, that starts kicking in within a couple of hours and then lasts for about 10 to 12 hours. And some of these kids are not going to need admission, some of them will. If you're worried that they're going to vomit the dex, or they do vomit the dex, or they're shut down and you don't think they're going to absorb the dex, your alternative is to give them some nebulized steroids. And if you're trying to buy some time, you can give them nebulized adrenaline as well, which just takes down some of the inflammation. But if you're doing that, be aware that it's quite a transient effect. So it's really buying you time for the steroids to kick in. It's buying you time to get an anaesthetist there if you're really concerned. Have you got any questions about croup? Because I'm just going to whisk through that one because it's scary, but it responds very well to therapy. Any questions from the floor on the chat, Fiona?
No, nothing at the moment.
Okay. So the next kid that we thought we would discuss is another really common presentation. So you've got a 7-year-old coming to ED with a bit of a history of a cough and a cold and a worsening wheeze for the last day on a background of asthma. So the parents have been giving salbutamol at home, but are concerned that she's getting worse and she's struggling to speak. So those are her observations at triage. Would one of you like to comment on what you're concerned about there?
The fact that she's struggling to talk, that's quite concerning. SATs being 91%, that's quite concerning.
Yeah. What about her heart rate and respirate? What do you think of those?
Oh, I'd need to look at a chart, but they seem a bit high.
So that's a really good point. So what I would say is you're pointing out that the normal range for different ages in kids is variable, and if you're not doing it all the time, or even if you are, it's pretty hard to keep all of those numbers in your head. So what I would strongly recommend is that you have a sticker or a little card in your ID lanyard that's got the normal ranges on, so you know whether you're worried or not. So this kid is tachycardic, tachypneic, but to be honest, I'm expecting her to be, and I would be more worried if her heart rate and respirate was slowing down, because that either means she's getting better. I don't think she's getting better because her parents are worried and they brought her to hospital and she can't speak. So if she was slowing down with her breathing and respirate, I'd be concerned that she was tiring and peri-arrest. So you know, we have to do something here, but actually the fact that she's tachypneic to me shows that she's trying to cope with what's going on at the minute. So have you seen, we have an asthma wheeze pathway, which is available on the intranet. I don't know how you get access to these on Nerve Centre now, so that's a question for your ED colleagues if you're doing your ED rotation. But the asthma wheeze pathway asks you, you know, it guides you through a bit of quick history and assessment. It asks you to do a PRAM score, which I'll come to on the next slide a bit bigger, but that's an assessment of severity. And then based on that assessment of severity, you're going to start some treatment. So if the kid has only mild wheeze or asthma, then you're going to give 4 to 6 puffs of salbutamol and then review them, and you might be thinking about going home. Whereas if you're moderate or above, they're very likely to need to come into hospital to the ward, even if we only keep them for 4 hours, to make sure that we can space them adequately. So anybody on this side, the moderate severe, are definitely going to be referred to paediatrics. The mild and maybe some of the moderates you might be able to turn around in ED. So this is the PRAM score. So for this girl, she would score 2 because of her low oxygen. I imagine that she's going to be working really hard. So you're going to look for that in kind of your tracheal tug, your supraclavicular recessions, intercostal, subcostal recessions. You'll see her using her accessory muscles. She might be in a tripod pose, kind of bracing herself to try and improve the efficiency of her breathing. She's very likely to have decreased air at the base, and she might have it all over. And obviously if she's got very decreased air entry, then we are particularly concerned about a silent chest and very severe asthma. And when we listen, we've got inspiratory and expiratory wheeze. So she's going to score kind of between the moderate and severe on this. So we would then start burst therapy. Is that a term you've come across in ED?
Yeah.
Yep. So we tend to use inhaled therapy via a spacer for most kids, unless they're in a lot of oxygen and are too breathless even to manage burst therapy. So for the life-threatening, we're going to be doing nebulizers, but for most other kids, we're going to be doing it via a spacer. It's less threatening, it's less traumatic, and it's also quite useful education for the parents. If a parent brings their kid to hospital and we immediately rush in with a nebulizer, in their head, that's what they expect every time. And if you can show them that actually you can turn these kids around quite nicely with a spacer, that's better, because that's something that we can reinforce on the ward, and then they can then go home and carry on doing as we're kind of weaning them off the subutemal. Has anyone got any questions for this bit, for the asthma? On the life-threatening bit, we are not only nebulizing, but we're also going into IV therapy as well. So IV magnesium sulfate, IV salbutamol, IV aminophene, but you're not going to be managing this independently in ED. By the time you get into severe life-threatening, you're going to have a paediatric registrar there, and I would be expecting anybody requiring IV therapy to be initially managed in resus and then managed on Kipling in the HDU area. It's a bit of a disaster if a kid with asthma gets intubated. They're very hard to manage on a ventilator, so we often throw everything we can at them and then step back once we've got them stabilised. We don't very often have to involve the anaesthetist.
I was just going to say,
Yep.
regarding wheeze and things, I think everyone gets a bit anxious about small children, as in I'm talking like 1 to sort of 3-year-olds with subcostal, intercostal recession, that kind of thing. But because of their anatomy, their chests will be more compliant with any increased work of breathing they have. So I personally, I don't know, Stephanie may disagree, I'm slightly less concerned about that age group. I'm more concerned about the like 7, 8, 9, 10 older who don't look particularly unwell, but they can't speak and they can't, they might sit slightly awkwardly and they're just kind of hovering on the edge of slightly tachycardic. Their saturations are probably just like 92, 91. They're the group of patients I'm more concerned about, because of their anatomy and the way that they generally don't actually seek help as early.
Yeah, so I'd agree. So under 5, recession is really, really common sign because their chest walls are so compliant. Over 5s, if you see any recession, it's a sign that they're working really hard. And by the time you get into secondary school kids, the physical signs might be minimal. And we've certainly had older teenagers on the ward who are even still managing to speak in broken sentences, but they don't objectively look too bad. They're a bit tachypneic, but you're not seeing them working particularly hard. You're like, oh, you know, how bad are they? And you do a gas, and bearing in mind that we tend to do cap gases or venous gases in paediatrics. We don't do arterial gases on awake kids. But you do a gas and suddenly you see a PCO2 of 8, 9, 10, and you're like, oh my God, they're about to arrest. And yet looking at them, they haven't got the same clues that you might see in the preschoolers. So they can be very difficult, and I would be quite nervous about particularly the teenagers, the poorly managed teenagers with asthma can deteriorate very quickly and take you by surprise. Mm. There's a question on the chat about how hypoxic would they be. So it's not really about how hypoxic they are, I don't think, for me, in terms of do I give them a nebulizer or a spacer. It's about how hard are they working, and do I think that I've got time for them to take spacer therapy without them dropping their SATs really, really low. So if this girl, if she's got SATs of 91, I'd be happy to give it via a spacer. But if I've got a kid in high flow oxygen with SATs of 95, and the moment I take them off oxygen, they drop to 78, clearly you're onto a loser there. So I would nebulize that one if they're working hard. Do you want to add anything, Fiona?
No, I would agree that I think it's dependent on the child and how well they're coping with or without oxygen as to whether you want to nebulize or give a spacer. And I think if you're not sure, just do what you think is the right thing at the time.
Yeah. So next case is a kid coming in seizing. So this is a pretty common scenario, I'd say. So, you know, you've got a kid with additional needs, known to have epilepsy, on Keppra, starts seizing at school. So all of these kids will have a healthcare plan at school and an individualised epilepsy plan for school. So the school might well, depending on the child, might well be very comfortable giving some buccal midazolam whilst waiting for ambulance. So this kid has some of that. The ambulance crew arrives, they give a second dose of buccal midazolam, and by the time they come to the ED resus, they are still fitting. And those are your observations in resus. So his heart rate is on the high side, as we might imagine, unable to get a blood pressure. Resp rate is 10. I'm going to tell you that I'm not very happy with that. SATs of 90, still seizing, generalized tonic-clonic seizure with dilated pupils, and the ambulance crew have checked the blood glucose for you and it's 7.2. So what would you like to do now? How are you going to manage a kid in status?
I really, really want some senior help, including an anaesthetist and a paediatric consultant.
Yep, not a bad call. So how are you going to get that in ED?
I guess you can either probably put out a paediatric cardiac arrest call.
Mm-hmm. So if you put out a paediatric cardiac arrest call, and it's not a bad thing to do, you will get, on the Conquest side, you will get a paediatric registrar, an APNP and an SHO, and you'll get anaesthetic cover and an ODP. If you want a consultant, you have to phone them separately. And on the Eastbourne side, if you put out a paediatric arrest call, I mean, this child should not be delivered by ambulance to Eastbourne. There's a reason for them not going to Eastbourne, because we don't have the same cover there. But say they started fitting in the car and parents just drove into the nearest hospital. If you put out that call at Eastbourne, you might get some support if the Scott unit was open, which would normally be a consultant and an SHO. But when the Scott unit's closed, there's no paediatric doctors on site. So the nearest paediatric doctor is at least half an hour away by car. So just be aware that the paediatric cover at Eastbourne overnight and in the evenings is less than at Conquest. But yeah, not a bad idea to get the help there that you want. So we'll assume that help is coming. What else are you going to do while you're waiting for that?
Going to start my A to E assessment.
Perfect.
whack on loads of oxygen.
Yeah.
Make sure that determine if their airway is compromised. Use an adjunct if necessary.
Yeah. So what kind of adjuncts are you talking about?
So nasal or oral, depending on their consciousness level.
So if I told you that you could put a Gill in and he was tolerating that just fine.
Okay, yeah, leave that in.
Leave that in. And are you, so I've told you I'm not very happy with a respite of 10 in an 8-year-old who's fitting.
Yeah, so I guess you probably want a bag.
Yeah, so you want the anaesthetist there, don't you? You want to support this airway. You want to start some bag mask valve ventilation with oxygen, and bearing in mind that you're doing that, if somebody can put an NG down and decompress his stomach so that he doesn't puke, that would probably be quite good as well. Yeah, good start. Then what?
Shall I let someone else go, or shall I?
You could pick a friend. Why don't you challenge one of your friends?
Alex, you can go if you're able to talk.
There's a clue.
Or anyone can put it in the chat, it's fine.
Oh,
he says he hasn't got a microphone.
Okay, I'll carry on. So we've got the airway sorted either with head torsion left or with the anaesthetist who's there. So we've got the oxygen, got the glucose already checked, and now we just want to give some IV lorazepam, and we check the trust guidance on what we give, and it's all here.
It is there. So bear in mind that this kid has already had 2 lots of midazolam and has got a respirate of 10. So I guess it's always one of the arguments, isn't it? It's like, how do we know that midazolam given by the school was given effectively? Are we going to count that as our first dose, or are we just going to start again? And different doctors are going to tell you different things. I think that pragmatically you need to be giving, you've been 10 minutes since the last benzos in the ambulance, and you need to give something now, and it's what you can get fastest for me at this point. So you need to get some access, and then it's what can you give quickly. I would say that if you give another dose of lorazepam, I think you need to be prepared that this child is going to stop breathing completely. So it's okay. I mean, it'll probably stop the seizure, but you need to be prepared for that, because he's already got respiratory depression on 1, maybe 2 doses. So you could try another lorazepam, or you could go on to phenytoin or phenobarbital, and I think either of those have pros and cons and doesn't really matter. What I would say is that for a child with known epilepsy, some of them, particularly the complex ones that are on lots of different meds, have individualized medication plans. So for example, we have some kids that cannot have paraldehyde. We have other kids that you give paraldehyde early because they always respond really well to it. And Fiona, you might be able to tell me where those are kept in ED now, but on eSearcher, they are often flagged as an alert within the patient documents as a kind of future care plan, something like that. And often the school or the family will have it as a handheld patient kind of, please treat my child with this type thing. So if they come with that, follow that. Otherwise, just follow the APLS guidance, which is here.
Yeah, I think we used to have folders for each child, but I don't think they're very up to date. And I think what you said about eSearcher, but actually my experience is most of the time the parent or the carer or the teacher will have it waving it at you as they come through the door, sort of thing. If not them, the paramedic perhaps who brings them in might also have it. Some parents are very particular about what their child should and shouldn't have, so it's not if they say, oh no, don't do that or don't do this, then that's quite normal behaviour for them, because they obviously are the expert really in their child and how it's managed, because you might have met them once, but they've met half a dozen health professionals in A&E resus So.
And the paediatric team might also know this child very well as well. So, you know, we have some kids that are frequent flyers when, as soon as ED call us and say this kid's on the way in, we know that we need to be there, and we know that we're going to, you know, jump a step because they never respond to this one, they always respond to the next, that kind of thing. So call us early, it's fine. Has anyone got any questions about that pathway? I know, I'm aware that we're kind of whipping through stuff, but it's the point of this talk is not to expect you to be comfortable that you can now go and manage each one, but just so that you know that there are protocols around and where to find them, and just highlighting if there's any differences between paediatric and adult practice, just so that you remember, oh, I need to look this up, it's a bit different to what I'm used to. Because you won't ever be doing this by yourselves, I promise. Okay. Okay, what about this one? So this is a preschooler who has who's generally been fit and well, but he's had a day of vomiting and abdominal pain on the background of 3 days of just being not quite right, bit drowsy, just no fever, just not quite right, and non-specifically unwell for a few weeks, really tired, not wanting to play. And the reason that the parents have called the ambulance today is because they've noticed that he's much drowsier, he's really not responding to them, and his breathing just looks really strange. So breathing really quickly doesn't look normal. And those are his observations in resus. So I will tell you that that heart rate is very fast, that blood pressure is low, the resp rate is fast, his SATs are poor, but we've got a poor trace, he's very peripherally cool, and he will open his eyes and squeeze your fingers to command, but then he seems quite drowsy and shuts his eyes again. What else would you like to know? No, already. What else do you want to know about this kid?
Blood sugar?
Are there any skin changes or rashes?
No rashes. He feels really cold peripherally, and he looks quite mottled peripherally, but no rashes, no.
Someone said blood sugar, and also what kind of vomiting?
So vomiting, whatever he brings up, but if you're asking me whether it's bilious, no, it's not bilious. It's just whatever he brings up. Can't keep anything down at the moment. And someone asked for a blood sugar. So how are you going to get that? Sorry.
Probably do a cap gas.
So you'd like a capillary gas and a blood glucose. Thinking of what? How are you putting all that together?
It sounds like a very septic child to me.
Yep, he could be septic. He could be, and I think that's an important thing to think about. He isn't febrile. I know that when you have kind of overwhelming sepsis, you could present cold or normothermic. I would say in kids, my experience is that they do tend to have a history of fever at least, and he hasn't got that. But yes, we should bear sepsis in mind. Anything else that would put together abdominal pain, vomiting, and altered breathing?
Did we get the glucose? Sorry.
We're going to ask for it now.
Could be DKA.
What do you think?
Yeah. DKA?
Mm-hmm. So how do you make the diagnosis of DKA on the gas? What are you looking for? You're right. What are you looking for?
So acidosis?
Yeah. So pH less than 7.3, and we grade it kind of mild, moderate, severe, depending on the pH. This would be severe. Yeah.
Nathan said metabolic acidosis because it's got raised sugar and ketones.
Yeah. So the clue's in the name, isn't it? So diabetic, so you've got glucose more than 11. If you have a patient with known diabetes, it is possible to go into DKA with a normal blood glucose, but it's pretty uncommon. And at first presentation like this, you're much more likely to see glucoses in the 20s and 30s or 40s. So we're looking for a raised glucose, we're looking for ketosis, so we do that on point of care testing, and we're looking for acidosis, pH less than 7.3, and a bicarb less than 15. Ketones, do you know what normal ketones are? Do you know whether 6.1 is a bit high, very high? Do you have a feel for normal range?
They're normally less than 4, is it? Or 2?
Or 3.
We've got less than 1 as well.
So in all of us, when we are well, our ketones should be 0.001. If you kind of fasting overnight, you might show a very small ketone response, but not very much. In a patient with diabetes, if they've got ketones more than 0.6, we're telling those parents, you need to keep an eye on this, you need to check your child regularly, la la la. If they've got more than 1.5, that shows that they are likely to be deficient in insulin for whatever reason. And if they're greater than 3, they're at really high risk of DKA. So if they're over 3, I'm thinking I want to be certain that this is not DKA before I relax. So and the kids that come in DKA, I normally see ketones kind of between 5 and 8. I think it stops reading at 8. So so yeah, anything above 3, you get twitchy. Do you know how to manage DKA in children? Do you know any differences between managing children in DKA and adults in DKA?
I imagine you have to be a bit more careful with the fluids.
Mm-hmm. Do you know why?
Because I don't really know why. I was thinking they're smaller.
I think that's a good point.
They are generally smaller, although not always. I mean, we do have, like, I've had patients coming in wearing 100 kilos, but yeah, this one's definitely going to be smaller. This one weighed 11 kilos when he came in.
Oh.
So yeah, I think fluids is the biggest difference to adults. So what the take-home message for you guys really is, it is different to adults. And so look at this guideline. So this guideline is available on the intranet. But you know what our intranet's like, it's hopeless. So it's a lot quicker just to Google search BUSPED DKA and then it comes up straight away. And it's a really, really well written, clear guideline that goes through step by step what you do at each phase. And we'll go through a little bit of it now just so that you have in your heads how it's different to adults, but we're not going to go through it in a huge amount of detail. But I think the biggest difference between adult protocols and the paediatric protocols does come down to the fluids. So if you have that in your head, I need to think about what fluids this child needs, and I know it's different for adults and I need to look it up. I think that will be a really safe place to start. But some of it you already know. So you're going to do your ABC assessment. You're going to give them high flow oxygen because we just do. It might help, it might not, but we do. We're going to assess their breathing and we're going to be thinking, am I happy that this child is protecting their airway? Do I need an anaesthetist right now? And if I'm worried about vomiting in the airway, then you're going to be thinking about putting an NG down. So oxygen, consider an NG and think about whether you need an anaesthetist. And obviously you're going to have the paediatric registrar here managing this with you in AD. Then you're going to go on to your circulation and you're going to try to get 2 IV lines in, and that's going to be phenomenally difficult because this kid is really shut down. So if you can get 1 IV line in, you're winning, and you're hoping that once you've fluid resuscitated them, you might be able to get a 2nd IV line in. And the reason we want 2 is because we're going to run fluids and insulin through 1, and we're going to be taking really frequent blood tests and blood gases and blood glucose tests. And so the 2nd line will be for sampling. So somebody's going to have a go at an IV line. Realistically, that's probably going to be one of the paediatricians or the anaesthetists, but if you're very confident, that's fine. you're going to put them all on cardiac monitoring, and then you're going to assess what fluid bolus that they need. So every child in DKA is going to get a fluid bolus, but the volume of the fluid bolus and the speed of the fluid bolus depends on how sick they are. And the next slide is going to talk about that. So we're going to give them their bolus, then we're going to reassess them. Then we're going to work out what fluids they need longer term over the next 48 hours. And after you've done all of that, that's when we start thinking about insulin and stuff. So there's quite a long period at the beginning where you're doing some really basic, simple stuff, giving them oxygen, protecting the airway, getting access and starting some fluid before you do any of the complicated maths or anything like that. Okay. When I'm talking about assessing the bolus they need, what this guideline says is you have to assess whether this kid is shocked or not shocked. So most kids in DK are not going to be shocked. And if they're not shocked, we're going to give them 10 mils per kilo of normal saline, and we're going to give that over an hour. So you've got a whole hour to work out things like your insulin infusion, to get your second line in, to get all your monitoring and do all your notes and everything. So it's not as stressy as it might first seem. If they are shocked, we're going to give them the fluid bolus that you're used to giving to children in shock, which is 20 mils per kilo of normal saline, and we're going to give that over 15 minutes. And then we're going to reassess and think, has it worked? Do they need another? If they need another, I'd probably only give 10 mil per kilo and reassess, because I am a bit angsty about giving a lot of fluid to these kids too early. So when we're talking about whether they're shocked or not shocked, all of these children are going to be tachycardic because all of them are going to be dry. All of them are going to have fairly cool peripheries, and their peripheral cap refill is probably going to be prolonged. But if you've got prolonged central cap refill, that's a sign of shock. So normally your cap refill, you press for 5 and then release, and it should refill within 2 seconds. So if you've got longer than 2 seconds centrally, that's a sign of shock. You're going to feel their peripheral pulses and feel whether these pulses are weak and thready or whether they are good volume. And you're going to look at their blood pressure. And this kid had a low blood pressure, didn't he? And if I said to you, he had a low blood pressure, his central cap refill was 4, and his radial pulse felt really thready, that would be signs that he's in shock, he's decompensated. We need to give him 20 mils per kilo now, and then reassess, and then start thinking about the longer fluids, the longer fluid regimen after that. I think this bit is quite different to adults. Does anybody want to ask me anything about this bit?
Nothing.
Deadening silence. Fiona, have you got anything you want to add for this bit?
No, I think the fluid is the significant thing. There's likely to be lots of questions about what's going on from parents. I guess that might be the other thing to consider. I don't think if as the FY2 in A&E and the parent says to you, what's going on? Have they got diabetes? Someone said diabetes. Yeah. It's just being conscious of what you're saying around the family until you're sure about what it is that you're going to say to them, I guess.
Yeah.
Which actually applies to most things, because I've seen lots of people, whether they're septic, whether they've got asthma, there's lots of clinicians around talking over the top of everybody, and parents will be listening to everything, and even the child might be listening. So probably a good bit of advice for me, as much as everybody else, to remember that there's lots of ears listening all the time.
Yeah.
I've got a question about the shocked and not shocked. Yeah. Once we've given them 20 mils per kilo over the 15 minutes, do we reassess? And if we think they're still shocked, do it again? Or do we move on to the not shocked bit?
So you reassess, and if you think they're still shocked, I'd give another 10 mil per kilo. and then you reassess. And if you think they're still shocked, I would move on to inotropes. So I wouldn't give more than 30 ml per kilo in total as fluid bolus. I'd move on to inotropes. What I would say is that not every child, so every child is going to need some fluid. Not that many are going to need the 20 ml per kilo fluid, and hardly any at all are going to need more than 20 per kilo. So it's not a decision that should be taken by the least experienced member of the team. It should be being discussed with the consultant on call. If you're going above 20 mils per kilo, I'd suggest, because it's really uncommon. And the reason that we get angsty is we're trying to balance up. You know, you have to fluid resuscitate them because otherwise you're at risk of thrombosis, your acidosis isn't going to get better, you know, your renal function's taking a hit, all of those things. But children are at increased risk of cerebral edema compared to adults, and that's a real risk and a real cause of morbidity and possible mortality in this group as well. So what you don't want to do is flood them with fluid without thinking about it. You want it to be considered and reconsidered every time you do it, and reassessed, and make sure that your therapy is working and that you're taking appropriate advice.
I see. Thank you.
This won't make any sense until you've actually sat down with a kid and done it, I don't think. But basically, once you've given that first bit of fluid in A&E, what we then do on the ward is calculate what they need for the next 48 hours in terms of their maintenance and to replace the deficit. And replacing the deficit is worked out according to their pH. And we also take into account whether we've given them resuscitation fluid, the 20 ml per kilo, which we don't include in any of our calculations, or whether we've given them that 10 ml per kilo, which counts as part of their rehydration over 48 hours. I'm aware that that's gobbledygook. When you go through it step by step in the guideline, it makes a lot more sense. But these are the kind of things we are working out. And what we're planning on doing is rehydrating them over the next 48 hours and taking things quite slowly. One of the important things I'd say for ED is that it's really helpful if we have a current weight to work on so that we can work out the fluids and the insulin accurately. Because if you go on calculated weights or 50th centile for that age or anything like that, we might get the fluids and the insulin quite wrong. So if at all possible, you want to get an accurate weight, even if you're doing it kind of child held in mum's arms and then subtract the mum's weight from it, that kind of thing. But if we can get a weight on the day, that's really going to help with the therapy. And then the insulin is here to say that we're not even going to start the insulin until they've had 1 to 2 hours of fluid. So we have got plenty of time to look up the guideline, to work it out, to do the maths. There is no rush about any of this. A couple of hours after starting fluid, we're going to start insulin. What that means is that on the Eastbourne side, it might be that you're transferring a child on fluids alone, and then we start the insulin when they arrive at Conquest to the inpatient unit. And on the Conquest side, it's likely that they won't start insulin until they reach Kipling Ward. Make sense? It's a really long guideline, so I can't really cover it in 10 minutes, but it's more to highlight, please be careful with the fluids. Please remember there's a separate guideline to look up, and please don't stress about the insulin because you're not even going to start that for 2 hours. Okay. This case is a girl that came into the hospital about 4 years ago, and we really mismanaged her. So with her and her grandmother's permission, I use her in teaching sessions. So she had chickenpox and was recovering from chickenpox. Her lesions are all beginning to scab over, and she was generally getting better. And then suddenly she developed high fever. So by the time of presentation to ED, she'd had 2 days of very high temperature and then about 12 hours of increasing work of breathing and cough, and was really quite unwell. And so grandma brought her into ED, and those were her observations at triage. Would anybody like to take a punt on how those observations look, whether you're happy with them or what you're unhappy with? Doesn't matter if you get it wrong, except that we're recording it and everyone will know, but apart from that, it doesn't matter if you get it wrong.
So I'm definitely worried about her low SATs and the fact that she's needing high flow oxygen to have good SATs, and she has a high respiratory rate as well, and she is tachycardic, and I think the BP is a bit lower than we'd expect as well.
The blood pressure is definitely lower than you'd expect. So normal blood pressure in kids, you can kind of go 90 plus. Their age gives you a rough idea. But like I say, it's better to have the table that's got the normal ranges on, because it's really hard to keep in your head. But anything less than 90 at 9 years old is definitely low. And is low blood pressure a late or an early sign of shock in kids?
Late.
Quite late.
Yeah. So you've correctly identified the things that we're worried about, which is one up from what we did on the day, because we didn't appreciate any of this really. So what we were worried about on the day was that she had low SATs, so they put her in high flow oxygen, they got a chest x-ray, and she did have some chest x-ray changes. So they thought, okay, so she's got a pneumonitis related to her chickenpox, and that's what is going on. But they didn't think about the heart rate, and they didn't think about the blood pressure, and they didn't give any fluid. And when I say they, I mean the hospital, so ED and paediatrics both.
So sorry, so someone's put, or Nathan's put PIMS, although I think this might be pre-PIMS, and then also Kawasaki as a query differential.
Okay, shall we come back to those if we've got time at the end, because both of those things, so PIMS is vanishingly rare, and Kawasaki is a good thing to think about, but not really applicable here. And what I'd like us to concentrate on here is sepsis, which is much more common. So if we do the sepsis bit first, and then I'll come back to those if we've got time. Is that all right, Nathan? So have you seen the Sepsis 6 tool in adults? I'm hoping yes. We've got similar looking ones in paediatrics, just to highlight that because the values down here for your tachycardia, tachypnea change according to age, you need to pick up the right age screening tool, just so that you get the right values and you know whether you're scoring it and red flagging it here. So if we had thought for this girl that this might be sepsis, and if we had picked up the sepsis 6 sheet, which we didn't do, she would have got a red flag for tachycardia, she would have got a red flag for tachypnea, a red flag for the low saturations. If we'd asked the right questions, she'd also have scored, because she hadn't actually passed urine in 18 hours, but nobody asked that question for several hours later. And one of the things to consider with her heart rate, which I think I sent to you guys, but I didn't update on that screen, was that when she came in and she was this tachypneic, she wasn't pyrexic. So we very often see pyrexic children with very high heart rates, and that is very common. And what you then need to reassess is, okay, once I've brought the temperature down, what's their heart rate doing? And if they've got a persistent tachycardia, that's one of the red flag signs of, I'm not really sure what's going on here. I need to look a bit harder. There's lots of reasons a kid might be tachycardic. You know, they're scared, they're in pain, they're pyrexic, but we have to think about it. And one of the things we have to think about is, are they septic? And this girl was really tachycardic, very calm. And it was because she had sepsis. So we didn't spot it, and she got diagnosed a bit late, but she did do okay. But the reason I use her as a teaching session is because when it was spotted and we started giving her fluid therapy, we very quickly got up to 40 mils per kilo. We then electively intubated her, not because her respiratory status ever went off. Her respiratory status was always fine and she was always talking to us all the way through. But because we'd given so much fluid and she still had refractory hypotension, we electively intubated her and we started inotropes, and we arranged for STRS to come down and collect her and take her up to PICU. And by the time that PICU took her up to London, which was about 8 hours after presentation to ED, she was on 4 inotropes, and she was as sick a child as I had ever seen. And her final diagnosis was that she had a group A strep bacteremia, so a secondary bacteremia from infected chickenpox spots. And that's what she had presented with. And although she did have changes on her chest x-ray, that was a complete kind of, she probably would have been fine with that had she not had the significant group A strep in her bloodstream. So the approach to sepsis is, I think, what you'll be used to from your sepsis 6 in adults. So we're thinking about high flow oxygen, we're thinking about early anaesthetic review. STRS is the South Thames Retrieval Service, which is the service that comes and picks up any child needing paediatric intensive care. We are going to be aggressive with our fluid therapy, usually. I'll come back to PIMS in a second, and we're going to think about inotropes. We'll need access. We might need the anaesthetists or the paediatricians to get access for us. We're going to be taking blood samples regularly, and we're going to be watching the lactate and being a bit concerned about rising lactates and lactates over 2. Remember that, as with this kid, you might need to ventilate to support their cardiovascular status, not just supporting their respiratory. And then we're going to give them broad spectrum antibiotics. So follow microguide, but for us, it's ceftriaxone in older kids and cefotaxime with amoxicillin in babies. And don't be duped by the very polite child that's smiling at you and talking, who's got a systolic blood pressure of 85 despite fluid resuscitation, because at some stage they're going to stop talking to you. So we just need to be a bit on the ball. Any questions about sepsis? Fiona, do you want to take over for this bit and tell me when you want me to go on with the slides?
Sure. This is the only reason Stephanie's invited me.
It's not the only reason.
So talk about burns. So some of you may have already heard this lecture, because I think some of you have already sort of had a bit of a paediatric experience. So this is a 1.5-year-old boy that is normally fit and well, who was in the grandparents' house, and essentially a hot cup of tea has been poured on the child. Accidentally, that's what we're gonna go with for this one. Yeah. So we have, thankfully. So this child has scalds to the face and the torso. All the clothes have been removed, and there's apparently, or there has been, some first aid around about 20 minutes. So observations are, if you're in A&E, you may get observations for this, but you might not. If you don't, I wouldn't panic too much, but we have a heart rate of 158 because the child's crying, no blood pressure, respiratory rate of 38, which is high because they're crying, their temperature is normal. And you can see that they have obvious erythema on their body and some blistering to the chest. So when we are talking about history for burns, what's really important, the history is actually one of the most important things, is where it happened, when it happened, how it happened, who saw it, what they did, what first aid they've done, has the child had pain relief, because you would be surprised how often this is forgotten. And then things like allergies and immunisations is important. So if this child needs a burns referral, they will be interested to know about tetanus status and immunisations. And any child with a burn, we are very interested in their social situation. So is this a safeguarding concern? Was this child left at home? Were they unsupervised? Were they supervised by the wrong person? Did it happen a few days ago and they've only just come today, or the child was actually at school and it was the teacher that brings them instead of the parent? Those sorts of clues are really useful for us being able to know whether we're worried about how the burn happened or not. Most burns that we see are scalds. That's the highest proportion of burns, but you can also have chemical, electric, and I've forgotten the other one. We don't get very much radiation burns around here, but you never know. So you're going to be examining the child. So we really want to undress this child, especially with an injury, any sort of injury. You want to undress and see what's going on, obviously in a place where that's appropriate. Burns assessment can be quite difficult, so I wouldn't say that you need to be an expert on, is this a full thickness, a partial thickness, is this erythema, is it, you just want to see, is there redness and is there a blister? Blisters are a good clue that actually it's slightly more than just a superficial burn. So the blister is actually the most important part of your burns assessment, because that's the bit, if you refer, that they're more interested in. So if you've just got a red scalded area that's not blistered, generally within about 24 hours that will go away. But the blistering is the important bit. And if you get a blister...
Do you want the diagrams up?
Oh, you can do if you want to, yeah. Oh yeah, there you go. So superficial, obviously the red one. The blister is, if there is a blister, you actually need to remove the blister, because you don't really know what's going on underneath, and that's the important bit for any referral. You don't want to send a picture to East Grinstead of a blister, because they'll only call you and say, please de-roof the blister, so that, and then retake the picture. So you'll probably waste some time, which is quite precious when you're working in the A&E department, and also with children, because you don't want to have wrapped it up and then have to unwrap it and then wrap it up again. If you've never de-roofed a blister, the nurses will help you with that. You can either do it with them or get them to do it. It's, you know, some people love it. The skin itself is actually dead, so don't worry about pain, but obviously the skin underneath will be sore, so we do want to think about pain relief. And I think the next slide's about slightly more, yeah. So we really don't want to see any white patches, and we really don't want to see any bits that have no sensation or anything like that. But I think your role won't necessarily be to, like I say exactly what type of burn it is. It will be more about the history taking and the initial first aid. So I always bang on about first aid in burns, because it's actually the most important thing to do for a burn for long-term outcome for that person, child or adult. So if you have a burn and you don't do appropriate first aid, then that burn will continue to burn, and then that will have an effect for scarring and then obviously long-term outcome. So 20 minutes is the gold standard. So 20 minutes, you must do a minimum of 20 minutes. It doesn't have to be freezing cold. It can be cool running water. So in A&E, there's a few showers. Throw the child and the parent or the carer in the shower. I know lots of nurses will actually do it. They'll get in themselves if they're in their scrubs. They'll just jump in. That's why it's important to give the child some analgesia. If it's a really significant burn, you can give them intranasal diamorph. You can give them oromorph. There's lots of choice for strong analgesia. Like I've said, remove the blister and then put a dressing over the top of it. Now, if you're going to do, if it's quite a significant size and you want to take some pictures, I would suggest trying to coordinate everything at the same time before you cover it, so that then you only have to do it once. So analgesia, take the blister off, get your dressing ready and your camera, take the pictures and then put the dressing on the top. So you might need a couple of people to help you with that. And then this is the TRIPS. So you need a TRIPS login, and you just send the pictures and they will, and then you phone them and they'll have a look at them and they'll advise you what to do, whether that needs to be seen by them. There are a few particular things, parts of the body that they would want to see. So a complicated burn would be something that is on the hands, the face, the feet, the genitalia. I'm just trying to think of these off the top of my head. Oh, thank you. If it goes all the way around, so circumferential burns, and if it's electrical, thermal, they and chemical, they want to see those. there is also a percentage of burn. So this is what I was talking about with the blister. So the blister will give you your percentage. The erythema isn't included as a percentage. Sorry, Steph, will you just go back one, please?
Yeah.
So East Grinstead will only see up to 5% in under ones and 10%, I think it is, in over ones. If it's anything bigger than that, then it has to go to a different burn centre. And I think the next one after East Grinstead is actually Chelmsford. But East Grinstead will coordinate that for you. So if they think that they can't deal with it, then they'll coordinate that for you. The next slide that Stephanie showed is an app that's quite useful. It can give you so the Mersey Burns, you just download it. If you look on the picture, you can see that this man is half red, and the FT that's highlighted in the corner, that means full thickness. And then it's already calculated for you at the bottom the percentage of the body that is. So you can do this. The PT underneath is partial thickness, so that would be your kind of blistering. Full thickness would be your white areas or your black areas. So you can do a rough guesstimate so that when you're talking to them on the phone, you can kind of say, well, I think it might be this. Most of the time, they'll make it less than you think it is, but it just helps you to know whether you also need to be considering fluid resuscitation for this child or not, because if it's over a certain percentage, and I think it is that 5 and 10%, then you do have to think about fluid resuscitation, which this app helpfully also has the algorithm for, because it's another one of those, a bit like the DKA, where the fluid is calculated over a certain time period rather than just giving like maintenance or 2 mils per kilo. So that's also, again, why time is really important, because you have to start your fluid resuscitation from the time that the burn happened, and you've got, I think it's 16 hours or something before you have to complete that fluid. So I think, is there another slide after that?
I haven't.
Oh, this is just the, this is the national kind of burns guide. So take the clothes off if you can, do the 20 minutes, 20 minutes, 20 minutes. And I would say I'm a bit distrusting of parents. If they tell me that they've done 20 minutes, unless they've timed it, I don't believe them, and I just do it again, because you can't do harm by doing longer. You can do harm by doing less than 20 minutes.
Yeah. So, and I'd say, as a mum who has set the timer on the cooker so that I can put my child's arm under cool running water, it takes forever. And if you don't have it on a timer, there's no way that you'd think it was 20 minutes. It feels like 3 hours. So yeah.
I would definitely, I mean, you can do it in bursts. You can do, because you actually have, I think it's up to, off the top of my head, 3-4 hours to do that 20 minutes. So if they come to you at 4 o'clock in the afternoon and the burn happened at 1 o'clock, you still have time to do that 20 minutes if no one else has done it. Once it gets outside of that window, that 3 to 4 hours, then you can't actually stop that burn injury. But before that, there is, that is the optimum time, 20 minutes. So when, your next door neighbour knocks on the door and says, "I've burnt my arm, what do I do?" Get them to stick it under and put the timer on. And cling film.
And cling film. Okay. So I think that's the end of our quick run through some cases. As I said, I'll send this to Anita, so you've got these resources. I'm going to plug Spotting the Sick Child. It's a free resource. It's got good videos on with clinical signs. So if you're feeling a bit foolish because we keep talking about children grunting and you've no idea what we mean, this is a good website to look at the videos so that you can see what a child with stridor looks like, a child with grunting looks like, typical presentation for a bronch, those kind of things. The videos are quite good. The voiceover is quite annoying, but the videos are good. South Thames Retrieval Service, as I said, is the PICU pickup service for us. Their website is awesome. So in particular, it has got clinical guidelines for all of the major things which are worth having a look at. It's got the drug calculator. So for this, you plug in your patient weight, press calculate, and it gives you all of your emergency drugs, which is very nice. So do that, print it off for the notes. It's got normal ranges. which you can do either on their age with an estimated weight or on the actual weight. So that will give you the estimated normal ranges for that child. It will also tell you kind of important things about central lines, ET tubes, that kind of stuff, and how to calculate your infusions. So just really helpful practical stuff that you might need in an emergency that you shouldn't be trying to remember. Paediatric Emergencies is an app. There is a free, the STRS have now got an app as well, but I think it's only available on Apple at the minute, but if you've got Apple, you can do that. Paediatric Emergencies is an app available on Android and Apple. There is a Paediatric Emergencies Lite, which is free, which gives you some access, but the formal app costs around £4 or £5, I think, and I'd really recommend it. It has all of the common emergencies in it, with links to, you know, the Resus Council guidelines, the STRS guidelines for that thing, for that for that condition, the CATS guidelines for that condition, CATS being the North Thames Retrieval Service. So it's a really useful place because it keeps all the guidelines in one place, and I'd strongly recommend it. And that will be on the presentation that we'll send to Anita for you guys to have. Sorry, I'm aware we've gone over time.
Thank you very much.
No worries. Nathan, your question quickly. So Kawasaki, not an emergency, but yes, think about Kawasaki. If you've got fever for 5 days in a really miserable, hot, bothered child with funny rashes, funny eyes, but it's not an emergency, it's going to be a referral to paediatrics for assessment. And PIMS TS has got a lot of press at the minute, but it is still really rare. I don't think it's something that you're going to miss. They seem to come either as younger children with Kawasaki similar symptoms, and you'll be referring to paediatrics from ED, or they're coming in as older kids, sometimes with kind of generalized abdominal pain, but refractory hypotension. So not a well child, a sick child that you're going to be asking for early paediatric support with. And during the process of all that support, we might then find funny blood tests, and the funny blood test results that we're seeing are very high ferritin, high trope, high BMP, high triglycerides, weird stuff that we don't normally test for in paediatrics. But these are not, they're not well children coming into ED and being discharged from ED. They're children that have got kind of refractory hypertension and are unwell and being referred on to paediatrics anyway. So I hope that, you know, I don't think you should be worrying about missing it. I think you'd recognise them as a sick child and referring them to paediatrics. So if that answers that.